Okay, Bismillah ar-Rahman ar-Rahim. Radiological assessment of an adult glioma. We, we, we will discuss introduction to glioma, conventional sequences, advanced MR technique, can we predict the molecular subtype, post-therapeutic assessment, and lastly, integration of the imaging into clinical practice. First, glioma represent a diverse group of primary brain tumor. 2021 WHO classification will be later on discussed by my pathologist colleague. This heterogeneous group present a significant diagnostic and therapeutic challenging. So accurate characterization is crucial for guiding treatment strategy and predicting the patient outcome. These challenges are due to the heterogeneity, diverse tumor type and grading with variable prognosis. Also, infiltrative nature make complete surgical resection is difficult. Treatment resistance to despite aggressive therapy, recurrence can occur. The role of imaging in glioma assessment: first is detection and differentiating glioma from non-neoplastic lesion. Second, help in therapeutic planning by predicting glioma, genetic or molecular subtype whenever possible, assessing true extension of the lesion, also detect relation to vessels, white matter tract, and cortical area. After therapy, post-therapeutic assessment, we have multiple challenging progression or pseudo-progression, pseudo-response, radionecrosis versus residual or recurrent lesion, post-operative sequelae or residual lesion. Starting with the conventional sequence, T1 weighted image pre and post contrast is essential for delineating the tumor boundaries. Post contrast enhancement indicating that the blood-brain barrier was disrupted. T2 and FLAIR imaging can detect edema and also non-enhanced tumor infiltration, especially in the low-grade glioma. So it's crucial for assessing the true extension of the lesion. But conventional sequences struggles with differentiating neoplastic from non-neoplastic in some cases, also grading the tumor, differentiating true from pseudo-progression or radiation necrosis in post-therapeutic stage. So what about the advanced MR? We have diffusion weighted image, diffusion tensor, perfusion weighted image, MR spectroscopy, then metabolic and molecular PET CT or PET MR. Starting with diffusion weighted image. What is the diffusion weighted image? It is the non-invasive MR technique that measure the random motion of the water molecule in the biological tissue. This provides insight into the tissue microstructures and the cellularity, which is altered in the tumor. So it's detecting the water movement, microstructure information regarding the cellularity, and early detection potential can identify subtle tumor changes post-therapy. If we pursue this is the tissue, and yellow is the cells, and the extracellular fluid, the movement of the fluid from intracellular to extracellular species usually occur in balanced way. But when this motion of the fluid in the extracellular space is restricted, is reduced, first in the cytotoxic edema, whereas the fluid is moving from the extracellular cellular to intracellular, so then the cell size was increased, will increase. So this is cytotoxic edema. This is why in the acute arterial ischemia the diffusion was restricted. Again, if the nature of the extracellular space itself is changing, and this extracellular fluid will be more, the viscosity of this extracellular space is increased. This condition like when biogenic abscess formed, so it showing restricted diffusion. Lastly, when the tissue showing hypercellularity, so this is in the malignant or high-grade tumor, the diffusion will restrict it. On the other hand, when diffusion will be more facilitated if the cell was damaged in the necrotic tissue. Also in the low grade tumor or in benign tumor with low cellularity. So this is in these cases the diffusion will facilitate it. Diffusion weighted image, particularly EDC mapping, which is computerized mapping, computerized quantitative mapping, playing a crucial role in the initial diagnosis and the grading of glioma. It can help in differentiating neoplasm from non-neoplastic lesion, help in grading glioma and identifying the highest grade, so it can use for target biopsy. First, differentiating neoplastic from non-neoplastic lesion. Here we have two different patients with ring-like enhancement surrounded by edema. But this two patients have glioblastoma multiforme, for example, metastatic or something else. When we adding diffusion, the first patient, the necrotic central non-enhanced part of the lesion showing restricted diffusion. So this is an biogenic abscess. But on the second patient, the central non-enhanced necrotic part showing facilitated diffusion. So this is necrotic tumor, either GBM or metastasis. Diffusion with EDC is almost the most accurate radiological way to grade the glioma. The more the EDC value, the less the grade of the tumor. So low grade glioma showing highest EDC, while grade 4 showing the lowest EDC. Some example, this is the subependymal giant cell astrocytoma of tuberous sclerosis showing facilitated diffusion with a calculated EDC 1.1. Another low grade fibrillary diffuse astrocytoma with facilitated diffusion and calculated EDC 2.1. On the other hand, multicentric glioblastoma multiforme showing restricted diffusion. Another glioblastoma multiforme showing the solid enhanced part showing restricted diffusion, but the necrotic non-enhanced cystic part showing facilitated diffusion. What about the diffusion tensor imaging? The idea here is we have two types of diffusion, isotropic or anisotropic. Isotropic, when the fluid is moving all around with no boundaries. So this is called isotropic diffusion. But when the diffusion of the fluid is limited to attract, limited to away, along the myelin sheath of the white matter tract, so it gives a ellipsoid pattern like that. So this is an isotropic diffusion pattern. In a computerized way, this is an isotropic directional dependent diffusion will be transferred into tractography or diffusion tensor imaging with tractography. This is the simplest way to clarify, explain the idea of diffusion tensor imaging, but it's much more complicated than that. So at the end of the day, we have this imaging which we can trace the corticospinal tract from the cortex to the spinal canal. So why we need this in glioma. The relation between the tumor and the white matter tract is needed in the preoperative and pre-therapeutic assessment. Also can used to predict the grade of the tumor. The more the aggressive changes in the tract, the more the grade of the tumor. So we have 4 pattern: deviated, or the tract passing through the edema, or infiltrated, or the tract is totally destroyed. Here, low-grade glioma displacing the corticospinal tract. Here, the tract is passing through the tract, the edema around. The tract is passing through the edema around the lesion in the oligodendroglioma. But here, with grade 3 glioma or grade 3 astrocytoma, the tract is infiltrated by the lesion. In the glioblastoma multiforme, in this case, the corpus callosum tract is totally destroyed by the lesion. Perfusion weighted image measure tumor vascularity and blood flow, indicating angiogenesis, and can predict the tumor grade. We have different techniques, different techniques used, including the dynamic susceptibility contrast, dynamic contrast enhanced T1 MR, and ASL, arterial spin echo. Arterial spin echo didn't need contrast administration, but need higher Tesla machine. And this how the contrast in the dynamic susceptibility contrast image works. At the end, we have relative cerebral blood volume map, and we can have a quantitative measuring to the relative cerebral blood volume. The high-grade glioma has more new angiogenesis, new vascularities with increased vascular tortuosity, so the relative cerebral blood volume is higher. On the other hand, the low-grade glioma has a hypovascular nature with less aggressive behavior, so the relative cerebral blood volume is low. Also, we can use perfusion weighted image to differentiate neoplastic from non-neoplastic lesion. Also can use to differentiate glioma from lymphoma. This patient with GBM, left parietal GBM, showing hypervascular, showing hyperperfusion with relative cerebral blood volume is much higher than normal. Okay, and also we can detect an infiltration beyond the enhanced part. On the other hand, low-grade glioma showing hypoperfusion with low relative cerebral blood volume value. What about the spectroscopy? A spectroscopy is a technique to measure the intracellular metabolites, whereby the echo is obtained from the body's analysis by the radio frequency component rather than making an image. So if the conventional MR, the echo transfer to image, in the MRS it's transferred to a curve. Conventional MR giving an anatomical data, but MRS giving biochemical information and function. But we have to know how we can use MRS. So at many cases we did MRS in non-indicated and non-suitable cases. Clinical request MRS, but it's not the case can be useful, and MRS can be useful. So we use MRS, but we have to avoid blood and blood product. So if we have a hemorrhagic lesion, we can't do MRS. Air, CSF, or much fluid, much necrosis within the lesion, fat, metallic calcification, or bone. The small cortical lesion couldn't be assessed by MRS. So we have to know when we can use MRS probably. So this is the normal curve or the curve of the normal tissue. In glioma imaging, MRS can help to determine this is neoplastic or non-neoplastic lesion. Neoplastic lesion showing increased choline, decreased N-acetyl aspartate, but take care, almost all pathology affecting the brain causing increased choline and decreased N-acetyl aspartate. Theoretically speaking, choline to N-acetyl aspartate more than 2 at TE144 or intermediate T is highly suggestive of tumor. But this rule have a lot of exceptions. In this case, we can differentiate low-grade glioma from cortical dysplasia by MRS. The cortical dysplasia giving almost normal curve, but low-grade glioma showing increased choline. And so we can differentiate glial from non-glial, primary from secondary tumors, as the N-acetyl aspartate is a neural marker, so it's present in the glioma, but not in the metastasis or non-gliotic tumor in the brain. But again, in the highly aggressive glioblastoma multiforme, the N-acetyl aspartate markedly reduced. It can be misdiagnosed as a metastasis. Again, can MRS differentiate lymphoma from glioma? Perfusion can differentiate it better than spectroscopy. But here in the lymphoma we have large lipid and lactate peak and markedly reduced N-acetyl aspartate. Again, glial or not, depending on N-acetyl aspartate. If glial, what's grade? Low-grade glioma usually showing -2. High-grade glioma usually showing lactate and lipid peak. The higher the choline to N-acetyl aspartate, the higher the grade of the tumor. Okay, lastly, metabolic or molecular PET imaging, FDG, less sensitive for glioma due to high normal brain uptake, but there is more tracer, more amino acids, a bit like meta and fit PET-CT, revealing increased amino acid transport in the glioma, offering superior tumor delineation, and it's used in differentiating progression from pseudo progression in post-therapeutic stage. So, can we, as a radiologist, predict the molecular subtype? Yes, in some cases. IDH mutant lesion gliomas usually showing T2 flare mismatch, okay, and this usually showing a facilitated diffusion. IDH wild type, there is no T2 flare mismatch showing necrosis and hemorrhage, and it's more enhancement more frequent with restricted diffusion. الأوليغودندروجلايوما هو IDH mutant and 1B19Q codylation, usually cortex, showing some calcification with foci of restricted diffusion. MGMT methylation status is of great clinical importance. It has been demonstrated to be associated with improved outcome in patients with glioblastoma multiforme. In the GBM, in methylated, the pattern of enhancement was mixed nodular, but unmethylating showing ring-like enhancement. Lastly, H3G34 glioma usually showing heterogeneous EDC restriction with heterogeneous with subtle contrast enhancement. So this is how we can differentiate the adult type diffuse glioma, IDH mutant, IDH wild, and other type by imaging. Lastly, the coming era is AI and radiomics, which transforming the glioma assessment, integrated the AI with to predict the genetic background, genetic and molecular background. Post-therapeutic there is a challenging in post-therapeutic glioma assessment. We have to identify residual or recurrent tumor, differentiating progression from pseudo-progression, quantify tumor response accurately, and standardize the assessment. We have some standard criteria to evaluate treatment, RENO and iRENO response assessment in the assessment, in neuro response assessment, in assessment in neuroradiology, in neuro-oncology, and also iRENO. This criteria is guide the clinical trials, but we have some challenging pseudo-progression, pseudo-response, and radiation necrosis. Pseudo-progression referred to increased contrast enhancement or to flare signal after chemoradiation of glioma, usually attributed to radiation-induced inflammation or demyelination, so there is breaking to the blood-brain barrier. Incidence is reported up to 30% of glioblastoma patient, especially in wild type. This patient have glioblastoma multiforme, did surgical removal. After 3 months after initiation of the immunotherapy, there is a enhanced lesion with marked surrounding edema. But look here in the perfusion weighted image, there is no hyperperfusion, so this is pseudo progression. No restriction, no hyperperfusion, so this is pseudo progression. After 6 months, there is a true progression. Another enhanced component, heterogeneously enhanced component with restricted diffusion and hyperperfusion. So now there is a true progression. Okay, do you notice the lesion here is somewhat regressed? Type. How we can differentiate true from pseudo progression? Perfusion is the best one, but when we did it technically accurate, technically true. Diffusion weighted image can assess also cellularity spectrum depending on the choline to N-acetyl aspartate. The tumor showing elevated choline to N-acetyl aspartate, but the pseudo progression is not. This study showing the relative cerebral blood volume comparing the true progression from the pseudo progression, EDC value and choline to N-acetyl aspartate. Another example of baseline. Then after 4 months, there is a lesion, now heterogeneously enhanced large lesion, but at month 5 regression and also a total resolution after 7 months. So the response, on the other hand, the reduction of the tumor size and enhancement, but this not due to tumor regression, but it's a transient effect of the therapy related to anti-angiogenetic agent or anti-angiogenetic effect. So also we have to differentiate this glioblastoma multiforme after chemotherapy, regression of the enhanced component, but later on the extension of the lesion in a diffuse manner to the hypothalamus and brainstem. This is one of my cases. glioblastoma multiform under chemotherapy. This is the baseline, and this is the today's study or the current study. After treatment, the enhanced component is regressed. The solid component on T2 weighted image is regressed. The edema was regressed, but the diffusion restriction increased. So what we can say here is this true progression, pseudo progression. Why there is a mismatch between the enhancement pattern and the diffusion pattern. So if the patient with glioma under anti-angiogenetic drugs, the diffusion can be restricted, and this study clarify why the diffusion restriction associated with this drug treatment in the recurrent glial tumor. This is a very important point. So we can't depend on one parameter. It's something like a puzzle. So I can say the diffusion is the best, the spectroscopy is the best, perfusion is the best. No, it's almost like a puzzle. We have to complete the picture. Lastly, radionecrosis versus tumor recurrence, tissue damage by radiation giving mass-like lesion. We use conventional MR depending on the pattern of enhancement. Perfusion is the best here. Perfusion is the best, or perfusion can be used to differentiate tumor recurrence from radiation necrosis. In spite this is a large enhanced ugly pattern of enhancement, but there is no hyperperfusion, so this is radiation necrosis. Diffusion also can use the spectroscopy, can use the hair. So this is to combine contrast with the spectroscopy with diffusion to differentiate pseudo-progression from radionecrosis. In these cases, we do all the techniques, and as I just said, we combined the parameter. Also, a bit MR using Fitbit, as we see Fitbit using amino acid tracers can also help us to differentiate. So in preoperative planning, we need to precise tumor delineation, identifying functional area and white matter tractography, grading and predicting prognosis, perfusion and metabolic perfusion metabolic diameters combined with radiomics, enhanced non-invasive grading for glioma, treatment response assessment, differentiating progression, pseudo-progression, response, pseudo-response, radionecrosis, or recurrence, targeting biopsy guidance. Again, almost the same. So for time issue, we have to work as a team to optimizing using of we can't did all techniques for all patients, for financial issue, for time issue, and for availability. So we have to work as a team, neuro-oncology with neuro-radiology, to give the patient the best care. Thank you so much. نص ساعة زيادة، 10 دقايق زيادة، كتير قوي 10 دقايق زيادة. طب أعمل إيه؟